Hello, everyone. My name is Katie Kowalski. I am new to NORD. I joined the team in April, and I'm glad to be working as the Senior Program Manager for Educational Programs. And I will be your host for today's webinar on self-advocacy and care coordination. This webinar is part of our free series of educational webinars for patients and for caregivers. We're glad you could join us today, and we hope you'll join us for future webinars in the series. Today's webinar is brought to you with support from Strongbridge Biopharma. I want to take a moment to talk briefly about NORD to any of you who are not already familiar with us. NORD is an independent organization that's leading the fight to improve the lives of those with rare diseases. We do this through education, research, advocacy, and patient services. You can learn more about NORD's programs, services, and resources, and how you can get involved on our website, which is at rarediseases.org. We offer programs that can help you along your journey. You can also follow NORD on Instagram, Facebook, and Twitter if you're on social media. And now I'd like to introduce our speakers. Jill Pollander is the Director of Patient Services at NORD. As a registered nurse, she has over 30 years of diverse professional healthcare experience, from the emergency department to long-term care, and a specialty in pain management and palliative care. She's a strong advocate for patients and for access to appropriate care and treatment. Laran Hyder serves as the Director of the Education and Outreach at the Neuroendocrine Tumor Research Foundation, where she leads efforts to improve research, education, and advocacy for the neuroendocrine cancer community. She leads the Foundation's efforts to provide quality educational resources to patients and caregivers. In addition to creating extensive online resources, NETRF offers patient education events all over the United States. So now I'm going to turn it over to Laran to talk with you about self-advocacy.
Thank you so much. Hi, everyone that's joined for the webinar. Thank you for being online today. I also want to thank NORD for giving me the opportunity to present. I am really glad to be participating. Today, I'm going to talk about self-advocacy, so particularly advocating for yourself as a patient in a healthcare setting. Acquiring some important self-advocacy skills will allow you to lay the foundation for a better and more satisfying care experience. So what is self-advocacy? If you read through the patient self-advocacy literature, you'll find all sorts of definitions and examples. Wright says that self-advocacy means representing one's own interests within the healthcare decision-making process. And Brashers defines self-advocacy as patient involvement in healthcare decision-making, and Wilshire says it is the ability to seek, evaluate, and use information to promote one's own health. These definitions are all great and they're all accurate, but what we'll talk about today is what patient self-advocacy really looks like in action and what skills are needed. Self-advocacy is not an instinctive skill. It has to be taught, explained, and practiced in various settings. Very few of us were born kicking butt and taking names and expertly asserting ourselves. The ability to effectively and appropriately advocate for oneself is a crucial, lifelong skill that needs to be taught and learned and practiced and supported. I like to think of patient self-advocacy in terms of getting a good, solid building foundation in place. All the stuff that goes into the groundwork of a solid base makes for a strong house. All the effort that goes into learning self-advocacy skills makes for stronger patient and physician interactions, increased disease education, better, more connected support, and making informed decisions about your care. So let's carry the metaphor here. I don't think anyone expected to get a construction lesson on this webinar, but I'm going to give a 2-for-1 deal. So first, to get a strong foundation going, you first need to find the right team to work with on the job site. You're the foreman. Being diagnosed with a rare disease, I know it can be scary and an isolating experience, but know that you're not alone. Being a good self-advocate also means that it's good to ask for help, and it is good to rely on a team of caregivers to help you through your journey. Seek encouragement and support with your circle of family and friends. Your family and friends are there to listen to you when you're feeling overwhelmed. They may not always have solutions or an action plan, but they do have ears, and a great hug can fix a great many problems. Friends and family can run errands, they can cook meals, they can help with childcare. Remember to both ask for help and accept help. Find the right experts to work with. You wouldn't hire an electrician to lay bricks and blocks. Make sure that as you assemble a care team, you find the right person to work with. You can use your network and resources to find that right person. Patient advocacy groups like NORD can help you find patient networks, related disease networks, and medical advisory boards. Many disease-based organizations like the NETRF Research Foundation offer searchable doctor databases that can recommend experts that have been vetted on their experience with particular diseases. Disease-based organizations sometimes also establish centers of excellence for their condition. This means that programs and the care teams are evaluated based on stringent criteria. Join a support group. Your fellow patients are often the best resources for doctor referrals, especially if you're looking in a certain location. Expert and informed doctors can really make the difference in your care and treatment. Try social media. Facebook can be a treasure trove of private disease-based groups. Patients and caregivers that don't always have easy access to support groups, they can turn to online groups to seek out information and expert recommendations. And online administrators, they're often patients themselves. They do a great job sharing information and connecting group members. I've seen this done so well over the last year, and their efforts need to be acknowledged for stepping in to sometimes fill an information void. A word of caution though, please carefully vet information sources when you use social media. Not everything you read on Facebook or Twitter is true. Also, if you feel uncomfortable in a group or you're not having positive interactions, feel empowered to leave. Medical information, medical literature. All of those journal articles and academic resources that your doctors read and publish in, you have access to those too. Use Google Scholar to access scholarly journal articles and search for disease information. The authors that publish those articles, they could be a great start in finding an expert to work with. Not all articles are always free. However, access to summary information is readily available. And academic medical centers. If you are lucky enough to live close to a hospital with medical school affiliations, use those resources. Academic medical centers tend to have the latest technology and treatments available, and they often offer clinical trials. Use clinicaltrials.gov to search for disease-specific clinical trials. Next up, if you're the foreman, that means you're the boss. You have the ability to hire and fire your team. If family and friends cannot offer you what you need, seek out people who can. Don't isolate yourself. If you are uncomfortable with your doctor-patient relationship in your care, you can get a second, third, fourth, or even 20th opinion. It may be time to consider working with another doctor or another team if your doctor doesn't seem to be really listening to you or doesn't seem to have the time for you, or even is offended when you ask too many questions. Consider working with another doctor if your doctor begins to make subjective assumptions about you and your life. And finally, consider looking for a new doctor if the doctor doesn't seem to be up to date on new treatments, or if the doctor is uninterested in doing the work to learn more. Trust. While trust is a critical element in every type of relationship, it is especially important in the doctor-patient relationship. Building trust will take time. When there is mutual trust, you feel more comfortable being open and honest with your doctor, which translates into better treatment plans and better treatment outcomes. But don't let trust blind you. It is okay to question your doctor and ask questions. Building trust can come from better communication. And finally, the hallmark of a great boss is really effective communication. Effective and respectful communication is important for successful self-advocacy. Consider every discussion a two-way interaction between equals. Remember that assertive communication is not aggressive communication. It is okay to feel empowered and assert your thoughts and feelings. It's not okay to yell, shout, belittle, or even be passive-aggressive. Ask questions. Prepare a list of questions ahead of your appointment. If you need more time for your questions, call ahead and ask for more time to be allotted to your appointment. Ask for help. Nurses, interpreters, social workers, and your caregivers are all available for your support. Take notes. Bring along a voice recorder to your appointment. Bring a friend or family member. Repeat what you've been told in your own words so that you make sure that you fully understand. Be open and honest. And if it's difficult to ask questions and remember parts of conversations at appointments, you can communicate in alternate ways. Schedule a face-to-face meeting, send an email, write a letter, or schedule a phone conference with your doctor. Or ask your doctor what's the best way to communicate with them so that everyone can have an opportunity to fully ask and answer questions. And finally, remember, doctors are people just like us. There's no reason to limit your communication with them. Remember to respect their time. However, you are a paying consumer of their services. Once you have your team in place, gather your tools and dig your trench. Educate yourself. Digging a deep trench, much like educating yourself about your disease, is hard work. It isn't going to be easy. And in order to be an educated patient, you're going to need all your tools at your disposal. And on the flip side of that, education and information will give you all the tools you need to help you advocate for yourself. Living with a rare disorder can add another layer of complexity to seeking information and being confident in your care decisions. Being a good self-advocate means using all your tools to make the hard work easier. The internet is your oyster. Google with a grain of salt. Not all resources are created equal. Double-check information and vet resources. Not all information is up-to-date, reliable, or accurate. Find a mentor. Finding a mentor or being a mentor is a great way to learn. Mentors can offer support, advice, and information. And like we talked about before, try social media or message boards to learn more and to source information. Just like using social media to find an expert, online groups can offer valuable information. And just like using the internet, not everything is accurate or reliably sourced. If it sounds too good to be true, it probably is. Education also means asking questions. Look for in-person opportunities to educate yourself. A great way to learn is to attend an education conference. Check back with your patient support group or an advocacy group for opportunities to learn and network at conferences. Look for unique ways to learn. Have you tried searching for books? I always say that if I didn't read it in a book, then I don't know about it. Learning can be visual or auditory. So how about trying audiobooks, or you can even try podcasts. The NET Research Foundation is gearing up to launch a new podcast series, and we've interviewed experts and patients all about their experiences diagnosing and treating an uncommon disease. If you're busy and learning on the go, a podcast could be out there just waiting for you to find it. Look on Apple Podcasts or Spotify and search by disease name. You really never know what you could find. Don't dig too deep. Stop. Medical information can be complex and it can be difficult to absorb, especially if you're tired, if you're unwell, emotional, or stressed. Give yourself some grace and give yourself breaks. Don't cram for the test. Study in bits and pieces. And slow down. Take the information in, absorb it, exercise patience, read the directions before jumping in. Remember, there's a difference between the people who look at the IKEA instruction manuals and those that don't. You can raise your hand if you have a wobbly Billy bookcase in your house. Impatient folks, you know who you are. Remember that you're already an expert. You know yourself or your child best. Being an educated patient or caregiver allows you to be an active participant in your care. And it's not just about disease education. Being informed and educated allows you to better understand your needs, your rights, strengths, and challenges. Research says that there is a direct positive relationship between patient education and patient satisfaction. Now that you've learned more about putting a team together to help you build a good foundation, you've learned about different tools to self-advocate, what does it look like all mixed together? This is the active part of building your foundation, mixing the cement and putting all the blocks in place to form the foundation. Patients and caregivers are interested in and expected to engage in decision-making regarding care. That's why you're listening today. And your engagement allows you to be an active participant in your care. But that requires that you put all your skills together to self-advocate. So here are some examples of what that looks like. The first skill we talked about today, so our first block, so to say, was making connections and finding support. Some challenges you might experience that require self-advocacy while trying to build your team include managing your relationships. So remember that hire and fire part, and that part about learning two-way interactions to support others and support yourself. Some of the things we also talked about, like asking for help, they can result in positive outcomes, like a greater focus on health needs and actually receiving the help and support you advocated for and used your skills to find. Without self-advocacy, you could end up overworked from trying to do it all yourself, or you can feel isolated or confused. So let's put that second block in place. We learned a lot about communication today. You may find yourself as a patient or a caregiver in a situation that requires that you advocate through communication. This could be trying to manage symptoms, sticking to a treatment regimen, or developing treatment plans. And what about managing the cost of your care? That takes empowerment and communication. Talk openly and honestly about symptoms, asking for adjustments to treatments, or request more information about costs so that you're 100% in the know about the financial burden of your treatment. With self-advocacy in these situations, you end up feeling better. Who doesn't want that? You can share in decision-making about treatment. Without self-advocacy, treatments might be ineffective, you could regret a treatment decision you made, or you could make costly financial mistakes because you couldn't effectively communicate your needs or ask for more cost information. And the last block is about being an educated patient. Remember digging the trench, it's a lot easier with good tools. Use self-advocacy to understand your options, research options, and prioritize what you want to talk to your doctor about. Education and advocacy allows you to smartly discuss options. With self-advocacy, you can have opinions and be part of a team that makes decisions. Without being empowered to learn, you could be in the dark about treatments or next steps, or even worse, you could have no say and no options. And now here's your foundation wall with all of your self-advocacy skills, the foundation of better care. The last thing I wanted to talk about is maintenance. So even with the best foundations, cracks can appear. Don't ever stop practicing or learning. It's a lifelong process to learn to self-advocate. Don't settle. Thinking you are doing good enough is not always good enough. Take opportunities to improve your skills. Don't settle for the way things are. Always want more for your care. There's always more to be done to advocate for oneself. Life happens. There will be bumps in the road through treatment. It's okay that upheaval happens sometimes. As our friend Dory would say, just keep swimming. As I like to say, just keep self-advocating. I think I should talk to Disney about that one. And when life happens or cracks appear, don't panic. You've got this. Remember your self-advocacy skills. Put them to the test. Relearn or seek out more information. Or, if you do panic and there's a problem that's really cracking your foundation or calling upheaval, call in an expert. Advocacy organizations exist for a reason. We are here to help. We're your phone-a-friend. And lastly, don't ever stop working hard. Self-advocacy isn't easy. Never give up and never give up learning. Work hard to improve your empowerment. Believe in yourself and believe in your abilities. Thanks everyone for your attention today. I hope that you enjoyed learning about self-advocacy and all the skills it takes to build a foundation for your care. I now want to introduce my co-presenter, Jill Pollander.
Good afternoon. Thanks, Laran. I'm delighted to be here with all of you today. I've been tasked with talking about care coordination. What is it? What does it mean for a patient with a rare disease, and how does it apply in real life? Well, if you have a knee injury, you see an orthopedist, probably one who specializes in knees. If you have cancer, you see an oncologist, one who specializes in your type of cancer. But if you have a rare disease, well, what do you do if you have a rare disease? If you're like most, you see lots of specialists and lots of healthcare providers. This is Owen and Dandelion. I'll leave it to you to figure out which is which. Owen's first point of contact in terms of healthcare providers was, as it is for most children, his pediatrician. While Owen had met all of his developmental milestones up till age 3, just after he turned 3, his mom noticed a decline in his coordination. He stumbled a lot and his gait was unusual. She turned to Owen's pediatrician. He didn't think too much of it, but sent Owen to an orthopedist, who ordered a few tests and evaluations. He then sent Owen to a neurologist, who ordered some of the same tests. Upon sharing that these diagnostics had already been completed, it became a tedious game of round robin as Mom requested and accessed copies of tests from labs and radiology suites. Then the neurologist sent him back to the pediatrician. The pediatrician became the repository for all of the tests, records, consults, and notes. Notes and questions, no answers or solutions. A family member stumbled on Duchenne muscular dystrophy while Googling Owen's symptoms. The rarity of Duchenne muscular dystrophy, or DMD, meant that his pediatrician was not well versed in the disease, its presentation, or complications. The pediatrician sent Owen to a geneticist. Owen was diagnosed with DMD at age 4. Now armed with the diagnosis, the challenge of care and treatment began. Owen is 12 now. Many individuals with Duchenne muscular dystrophy are now living into their 30s and beyond, and so the coordination and planning for optimum management are significant and include planning for improved primary care and emergency management. Not only does the DMD patient need to consider routine care and treatment, but what about hospitalizations? Will the hospital know how to manage the unique needs of the DMD patient? Will they understand the nuances and manifestations of the disease enough to know what's normally abnormal for the DMD patient? What about school? Will they understand what is and is not an emergency for the student with DMD? And can medication administration be managed? Developmental and mental health considerations? These will change and evolve as the patient and his or her disease do. Psychosocial care and transitions into adulthood. These will impact not only the patient, but the family. So what does care coordination mean? Is it the scheduling of appointments and follow-ups? Is it getting lab results to the multiple specialists involved in the patient's care? Is it planning ahead for emergencies? How about prior authorizations? And what about advance directives? It's actually all of these and more. Care coordination involves deliberately organizing patient care activities and sharing information among all of the participants concerned with the patient's care to achieve safer and more effective care. This means that the patient's needs and preferences are known ahead of time and communicated at the right time to the right people, and that this information is used to provide safe, appropriate, and effective care to the patient. Accessibility and continuity are the hallmarks of coordinated primary care. The primary care provider is often the first medical professional to hear a family's concern about their child and initiates the process that leads to a diagnosis. He or she is ordering the tests and consults and running the gauntlet laid down by insurance companies. The primary care provider will often be the person to inform the family that a particular diagnosis is suspected. The possibility of a diagnosis that must be delivered directly but compassionately, bearing in mind that these early medical discussions can set the tone for how patients and their families react to the flow of information throughout the diagnostic process. He or she can provide a much-needed source of stability and support as patients interact with a host of specialized medical providers. The goals are for the primary care provider to provide first-line care for acute and chronic medical issues, coordinate care with appropriate specialists, provide trusted advice and continuity of care across the lifespan, and optimize the well-being and quality of life of patients and their family members. The primary care provider is the decipherer of jargon and the answerer of questions. One of the things I hear routinely from patients, families, and clinicians involved in care coordination is that the only thing that stays the same is that nothing stays the same. So you've scheduled, organized, and communicated, but you're not done. It's never quite done. It is, in fact, a dynamic process that changes and grows along with the patient. Care coordination activities include establishing accountability and agreeing on responsibility. Who holds the records and who shares with who? And of course, the necessary HIPAA authorizations and releases must be kept current. Requesting and scheduling a conference call between the care participants may assist in making sure that all are on the same page. And you can request this. Communicating and sharing knowledge. Who needs to know what? Does the school know how to charge the motorized wheelchair? How is a particular medication administered? What's the best method for transferring the patient into and out of a wheelchair? When are tests scheduled for diagnostics? And how are school absences handled? I generally recommend creating and keeping a binder of records. I like tabs for contacts, medication, diagnostic tests, hospitalizations, and other pertinent data. Thumb or flash drives are also excellent tools, though I caution you that some providers will not let you connect your external drive to their system for fear of viruses or malware, so you might need to be schlepping your laptop if you go this route. Assessing patients' needs and goals. The goals at age 12 are very different than at age 4. And what about at age 20 and thereafter? Creating a proactive care plan. When your primary care provider is not well versed in your rare disease, it's important to facilitate his or her connection to your rare disease specialist. Again, the conference call idea works well here. Helping with transitions of care, and not just care, but caregiver and locations of care. Monitoring and follow-up, responding to changing needs, supporting patient self-management goals. Again, the goals at age 12 are vastly different than at age 4 and at age 20 and thereafter. Linking to community resources, for the patient and for the family. And what about respite care? Working to align resources with patient and community needs. The central goal of care coordination is shown at the center of this slide. It's to meet the patient's needs and preferences in the delivery of high-quality care. The colored circles represent some of the possible participants in a patient's care and information important to the care pathway. I've used Owen and his diagnosis of DMD to create this model. The blue ring connecting the colored circles is care coordination. It bridges the gaps or the white spaces along the care pathway. The role of care coordination is information sharing and communication across disciplines and settings, and with consideration of physical, psychosocial, and developmental needs across the lifespan. Continuity of care from pediatrician to adult primary care and subspecialists, including but not limited to record transfer. Facilitate and advocate for self-management as applicable. From a young age, people with DMD know that they are living with a progressive disease, and they should be included in healthcare discussions. When an individual shows an interest and ability to self-advocate, he should participate in discussions about his care and needs. It's appropriate to move from family-centered to patient-centered interactions and decisions. Healthcare decisions that are typically part of disease progression, such as those related to intensive care for illness, ventilation options, and management of heart failure, major physical changes, including loss of mobility, anticipated complications, so that potential interventions are considered in advance of acute medical developments and crises. Anticipatory discussions can be empowering for patients and can promote self-determination based on personal values and goals of care. Palliative care consultation and advanced care planning. We can look at this in the context of Owen's care coordination. DMD is characterized by progressive muscle degeneration and weakness, first affecting the muscles of the hips, pelvis, thighs, and shoulders, and later the skeletal muscles of the arms, legs, and trunk. By the early teens, the heart and respiratory muscles are affected. An example of care coordination for Owen is the synergy between medication management, mobility, pulmonary function, and nutritional needs. Owen participates in aquatherapy, which is tied not only into the plan of care established by orthopedists and physical and occupational therapists to maintain upper and lower body muscle function, but improved pulmonary function and the weight management plan of care. While these interventions can stand alone, the synchronicity and coordination have the added benefit of providing Owen with social support and a sense of accomplishment and well-being. All the pieces fit together and feel like a single plan with a number of participants, as opposed to 5 separate care plans. It may be Owen's diagnosis, but it is a collective effort that helps him to lead a fuller life. I'd like to introduce you to and talk to you a little bit about Kevin. Full disclosure, Kevin is my cousin. He's 26 years old and was diagnosed this past February with familial adenomatous polyposis, or FAP. Without going into great detail, the treatment is surgical removal of the colon. The alternative? Well, there is no alternative, as without the surgery, 100% develops into fatal colon cancer. So we're talking about a 26-year-old living hundreds of miles from family, now having to navigate the rare disease space. All of these questions, challenges, and hurdles, quite literally, being hurled at him. I will say that his and the family's research skills landed them at a medical center, an academic medical center, with a team adept not only at managing FAP, but at care coordination. The social worker, case manager, from day one assisted with wrangling all the moving parts. Kevin had just been laid off, so he was in between the last of employer-sponsored health care and COBRA. He was living hundreds of miles from family, though he did move home for his treatment. Add to that, the treatment location for his FAP was hundreds of miles from, well, everywhere. So transportation and housing during treatment were issues as well. Here's what care coordination looks like for Kevin. He underwent 6 weeks of radiation therapy at the academic medical center where he was receiving his care. Kevin, his mom and sister stayed at an Airbnb, and Dad came out to visit every weekend. 6 weeks away from home, 6 weeks away from work for his parents, and the usual and customary comfortable daily routine was missing. Then he was home for 6 weeks to recover and recuperate. He even got to attend another cousin's wedding. Then back to the medical center for surgery. It was supposed to be a 5-day hospitalization. It was 10. Fortunately, the housing accommodation was able to be made. By the way, do you know how simultaneously scary and boring hospitalization is? Fun fact, 26-year-olds are unimpressed by the television program offerings of daytime TV. Apparently, Nintendo Switch is a lifeline. Finally, he was home again for 3 days. Then he developed a fever. He had developed an abscess. The folks at the emergency department not only never heard of FAP, but certainly had never treated someone with the diagnosis or a complication. Fortunately, Kevin's parents had his health information binder in hand with information from the treating physicians from his primary treatment site. This was a really important communication tool and resource. He spent 7 more days in the hospital. The hospital staff did near daily battle with the insurance company on this. Prior to discharge, all records were requested so that they could be held by not only Kevin, but forwarded to his primary treating physician. In the midst of all this, there were major educational needs to be addressed: nutrition and hydration, post-op care, ostomy care. None of these are simple. None of these are quick. Then there's the not insignificant psychosocial challenges of livelihood, socialization, body image, and the future. Kevin has been home for 2 weeks now. He's on IV antibiotics being administered by his mom and dad. They're staggering who works what days. He needs follow-up scans to evaluate the healing of his abscess, and all of his needs, all of his learning, everything that's transpired needs to be communicated back to his FAP team. He's feeling somewhat better, but it will be a long road. There will be potholes, roadblocks. Navigating these require care coordination. So for you, that care coordination may fall in your hands. Laran spoke a little while ago about self-advocacy. Care coordination is self-advocacy. She mentioned that you are the boss. I was thinking more the leader, leading the team. You do the hiring. You marshal the resources. You call the plays, or call in backups to call the plays. You reorganize the team with the plays and the plans as needed. You are the decision maker. The options are yours. The team is yours, and the success is shared. Care coordination is a team victory. I thank you all for joining this webinar, and I wish you a smooth road ahead. I believe there's time for some questions now.
Yes, thank you, Laran, and thank you, Jill, for your excellent presentations. Those were very informative and filled with information that I'm sure is very relevant for today's audience. We've been collecting questions from participants during the webinar, and we're going to move now to a question and answer session. The team is going to try to answer as many of your questions as possible, though we may not be able to answer all of them. So if we don't get to your question, feel free to email us at education@rarediseases.org, and someone on our team is going to follow up with you. So with that, let's begin. This first question, Jill, let me ask you. Our audience member says, one of the most pressing issues within our community is getting the different specialists involved in the care of a patient to simply talk to one another. What are some of the tips learned from patient groups and others on this topic? So what might be some strategies to get different specialists to communicate with each other?
That's an excellent question, and unfortunately it's a pervasive one. You're the captain of the ship, you're the boss, you're the team leader, so it really will fall to you to make sure that that communication happens. And whether it's having someone write a consult and you hand delivering that consult or emailing that consult, or whether it's arranging a time for a conference call, it sounds like it might be onerous, but it really isn't. Physicians really do want to facilitate coordinated care. They want to know that the right hand and the left hand are not duplicating efforts. And so often the best strategy is to say, if I were to schedule a conference call, would you participate? What does your availability look like? And you ask that to Dr. A, Dr. B, and Dr. C, and you push and pull at those times until you find one that works, and you get everybody on a call at the same time.
Well, that's actually a really great suggestion. I hadn't thought of doing that, and yeah, it seems simple enough. Doctors are people just like we're all people, and they want to help their patients, so I think those are really good ideas. Now let me turn it over to Laran this time. Laran, can you share a strategy for dealing with primary care doctors who do not have a lot of familiarity with your chronic condition?
Sure, absolutely. I think that that's a great question. So I think that this is a hurdle for a lot of rare disease patients and caregivers, but use your resources. Doctors want to learn as well, so I think taking in your resource material and your education material and sharing those with your doctor is really the best tip that I can give when it comes to educating your primary care physician.
Yeah. Anything you would add, Jill, to that?
I would. You are the most knowledgeable about you. You're the expert. So share your experience. Share what you are going through, what you feel, what you learn, what you know. Share that with your primary care physician. Share that with your rare disease specialist. And those communication tools, whether it's sending an email back and forth, whether it's setting up that conference call, you're the expert. You know what works for you and what doesn't. You can advocate for yourself in those, in those things that work and that you know.
Oh, that's great. Okay, now there's a question. This is coming in live, and it's really resonating with me. But and so I'll toss this up and see if either of you want to take it on. But the question is simply, is it normal to feel overwhelmed? Is this normal and common for rare disease patients or caregivers to feel overwhelmed?
This is Jill, and I would say absolutely it's normal to feel overwhelmed. Think about all of those things that you're dealing with on a daily basis. I would say it would be more unusual to not feel overwhelmed. But like everything that we handle on a daily basis, you take one step at a time. You figure out where to start, and you move forward from there. Use the resources that Laran talked about in terms of, your support system.
Great, thanks. Here, Laran, let me ask this one for you. Our listener says, it's easy to feel emotional and get flustered when you're advocating for yourself or your loved one. Do you have any tips on how to maintain your composure when having these conversations?
Yes, great question. Practice. Practice, practice, practice. I think that self-advocacy, as I said, really is a lifelong skill that it takes a long time to learn, and you constantly have to practice. And as we've already talked about, it's easy to feel overwhelmed. So losing control of your emotions when you're already overwhelmed, yes, that happens, and it's okay that that happens. But to really take control of how you're feeling when you are really having an overwhelming experience, practice. You can model behaviors at home with your family and friends. You can practice having those difficult conversations with your family and friends. And in fact, when I was doing some of the research for this presentation, I found that some researchers are working on games. So games that actually teach patients and caregivers about talking with their doctors and interacting with their doctors and really being able to bring some clarity to their communications.
Oh, that's a great suggestion. I actually didn't know there were resources like games out there, so I think that's a great idea. So Jill, since you're in our patient assistance division, I think this is a great question for you. It says, where can rare disease patients with little known conditions access help? How would I get funds to travel to a doctor or to a hospital that has experts?
Wow, that's sort of a complicated question. So Laran talked a little bit about the research that you can do online to learn more about your own disease. The rare disease specialist that you're working with can certainly help you to get more educated. An academic medical center is a great resource as well. In terms of resources for patients and resources in the financial realm for how you pay for care, treatments, and mileage or travel to a site, there are patient assistance programs that are out there. NORD has patient assistance programs, disorder-specific programs, but there are others out there as well. It does require some resource searching and researching. Advocate foundations, the National Patient Advocate Foundation is a good resource. They have a ton of resources across the spectrum. We're happy to help. Reach out to NORD, give us a call. We have information services, and we'll try to help you track something down.
Oh, that's great. Thank you. So next question, Laran, is what can be done to ensure that doctors slow down and listen to patients and caregivers and explore all the options with an open mind, particularly when dealing with complex patients who have rare conditions or multiple conditions?
Sure, absolutely. So time. Ask for more time. Healthcare is a business and you're a consumer, so make sure you get what you're paying for. Some of the things that we talked about at the beginning of my presentation, like calling your doctor's office when you are scheduling an appointment or when you're having an upcoming appointment and asking for extra time, that's one strategy. Another strategy is keeping a list of your questions so that you can be organized and you can prioritize what your questions are so that you can really slow down yourself and slow down the doctor and explore options. And then finally, I think bringing literature with you or communicating with your doctor ahead of time just to reference education materials could be really, really helpful.
Okay, great. Those are excellent suggestions. This next question, I think I'll send to Jill because you gave the great examples, and in fact I loved the fact that you told stories and used those as examples, but I remember Owen was being bounced from doctor to doctor and specialist to specialist, and this question says, what is the role of the primary care physician? So which doctor should be in charge of my rare disease treatment? Is it the primary care doctor? Or should my primary care physician coordinate all of my specialists and I expect them to communicate with each other and then it, basically says, what's actually the best strategy for dealing with primary care doctors who don't have a lot of familiarity with your chronic conditions? So, Jill, what do you see as the role of the primary care physician in care coordination?
So the primary care physician often is the one who coordinates all of the care. But let me take one step back. In terms of who should be in charge of your rare disease treatment and whether it should be your primary care provider, the answer really depends on how your disease or treatment manifests and is managed. So if your rare disease is at the forefront of your medical needs, then the rare disease clinician takes the lead. If it's more of a background issue, then the primary care doctor takes the lead and the rare disease doctor acts as the specialist or consultant. So it's not about expecting these practitioners to coordinate and speak to each other, but it's rather you advocating for them and facilitating that communication. You're the center of the care, so you encourage, you coax, you facilitate that communication. Not only is it in your best interest, but it really is in theirs as well. And in terms of those primary care docs who don't have a lot of familiarity with your condition, I think Laran addressed this to some extent. This really is an opportunity for both you and your rare disease specialist to teach and mentor your primary care physician. You're the expert on you. You share what you know, and you facilitate that collaboration and communication between your rare disease specialist and your primary care physician.
Great. So the next question is coming. I'll ask you this one, Laran, and it's about the hospital setting. And this person is asking the best way to advocate for yourself in a hospital setting, and particularly if you feel you're not being heard or your needs aren't being met, but without being seen as being difficult or non-compliant.
I love this question. Thank you for sending it in. So assertive communication is not aggressive communication. So I think that sometimes people confuse assertiveness with being difficult, being sharp, losing your temper, or even having a bad attitude. And it's important to remember that that's simply really not true. Learning to assert yourself takes a lot of confidence building, and it takes a lot of communication skills. But it's okay to feel empowered, like we talked about. It's okay to ask questions. It's really okay to voice your opinion. When you are in a hospital setting and you are learning to advocate for yourself, be firm and be insistent, and really be positive. I think there's a big difference between having a positive attitude and being optimistic when you feel you're not being heard. But as I said, it's not okay to really yell or belittle or lose your temper. And the last thing that I'll say, just to address this to be short, is don't ever worry about being made to feel like you're a difficult person. You're not. And build your confidence and really believe in yourself and believe in your skills.
Oh, that's a great answer.
I would add one thing to that. Thanks. The reality is sometimes that you and your doctor are not a good fit. Sometimes you don't click, and sometimes a breakup, if you will, is necessary. And that's okay. You can respectfully tell your physician, I appreciate the time we've partnered together, but I'll be making a change in my care provider, or I need to make a change in my care provider. That's okay.
Yeah. Actually, that gives me a segue to a question that's coming in live from the audience. And this, our participant says, it's great to say you are the boss, but for those in our community where surgical intervention is currently the only treatment method, being boss of a program while you're under general and in recovery is simply not possible. We are coordinating care often between 4 to 5 specialists, including an oncology team. How do those patients drive their bus when that bus is often hours away from their home? And I'll ask either one of you to jump in.
I'll be happy to jump in. So you're probably not driving the bus while you're under general anesthesia. I think that's frowned upon. But you can drive the bus prior to that. You can drive the bus after that. And it really is about communication. You're juggling a number of different disciplines, a number of different specialists. And you do that by having your needs, your goals at the forefront. You look at, what is my goal for this piece of my treatment? What do I want to accomplish? What do I need to accomplish, and how do I get that done? So during the surgical piece of your treatment, yep, the surgeon's driving the bus. Think of him as giving you a bit of a break. But as soon as you're done, now you're back in the hands of the post-op team. You're back in your own. You're back in your own hands, and you're able to call those shots. So I think sometimes you do have to relinquish that. You know, as I said when we were talking earlier, sometimes somebody has to play backup, and you let them take the lead for the time being until you're ready to resume that lead role.
Yeah, I think I'll just follow that up. I'm sorry. I think I'll just follow that up as what Jill said. You can tap in and tap out. Appoint someone to be your advocate. And that could be a family member, a caregiver, a friend, or even someone within the hospital system.
Okay, great. Well, unfortunately, our time has passed very quickly and is about up. So I want to thank Laran and Jill again for your engaging presentations and all the great answers to our questions. And I'd also like to say thank you again to our supporters at Strongbridge Biopharma. If you have a question that didn't get answered today, or if you have a suggestion for a future NORD webinar topic, please email us at education@rarediseases.org, and someone on the staff will follow up with you. And lastly, I want to thank all of you for joining us. We're really glad that you were with us, and we wish you a wonderful day.